mine is, yeah, like him, like her, like him, all that's been said. I think that I would like to stress, as a working NP, there is not going to be a shortage of patients. Anything that we have learned, our acuity level is climbing. Things that we used to in the dark old days when I was in nursing school, things that we used to have in hospital. I'll just give you my one example because it kind of puts it in perspective, but somebody had an open gallbladder being removed and they were in hospital for 5 days. No comorbidities, healthy person. She was in there on the 3rd day. I was this nursing student. I don't know what I was doing because she was walking around doing everything, didn't need pain medication, nothing. Yeah, she got to stay there for the full 5 days. Okay, how many people do you see walking around perfectly able within a healthcare setting? Not very many of them, right? They don't get a bed anymore unless they've got multiple comorbidities, they're sick, there's lots of stuff going on, multiple healthcare disciplines trying to work with this patient to optimize health. And so for that reason, I don't think we're running out of people. I work primarily in the primary care field. There's lots of people that are not rostered, do not have family physicians, do not have access to timely care, are wasting resources that could be used elsewhere. And again, everybody knows, healthcare system, it has no money. That's not going to change anytime soon. So similarities, yes, I think there are a lot of similarities with both of the training. I think there's a role for NPs, I think there's a role for PAs. In my background, while it is really such a small amount of what's out there, I did do my training in the States, so I did have some access to some PAs. None of them were in the primary healthcare field. They all tended to gravitate towards the acute care field with the specialists. So I saw a lot of them, for example, and again, I'm a little microcosm of what's out there. I'm not even pretending to say that I know the real scope. But a lot of them associated with the surgeon. So a cardiovascular surgeon would often have 1 or 2 PAs. So in the OR with them, doing the follow-up and working sort of that surgical side. Derm, they had a PA that was doing a lot of the punch biopsies that had to be done because there's a gazillion reasons and they're only getting worse and they're only getting, I mean, we don't have derm here anymore. I don't know about you, but wait time to see a dermatologist, 6 to 9 months, easy. And that's urgent stuff, a month. So we need people out there. We need people to specialize. We need people to work within the scope. So in terms of similarity, I think there is a lot. I think everybody's going to try and cluster for their job and their security, but I don't think that that's going to be the ultimate issue. As I said, I've worked with PAs, but they tend to be more specialist, acute care driven. The ones that I have worked with, I have not seen any in primary care. The other thing that I would point out is one of the reasons, well, it's not sort of the foundation anymore, but one of the reasons that the NPs came along, again, in a primary care setting, was to facilitate the family practice docs. So I worked with a group of 8 family physicians. The reality was there was lots of people with colds and sinusitis and all that kind of stuff that they were coming through that needed the education, needed to be told they didn't need an antibiotic. And equally so, there were people with acute appendicitis and the worst headache of their lives and all of these kind of really big red flags that needed to be dealt with. Well, going back to John's comment, they can only be in one place at one time. So a lot of the NPs were brought in to say, you deal with a fairly chronic, stable population initially, so that I can use my further training. I mean, I don't discount that medicine has had more training. They've got their specialty field, they know the stuff, so that their practice was more enjoyable for them. They weren't seeing the coughs and colds as much. They could use their full scope. Does that even make sense? Just so that they were actually getting pleasure from their job rather than just the run-of-the-mill stuff. So it was another reason why we brought people in, just to try and help with the sheer numbers. So further steps. I think one of the hugest barriers, is that even a word? I don't know anymore, is the lack of scope of practice for the PAs. I know that they are in different places in the hospitals, and because they are an unregulated healthcare profession, certainly I can only talk at a nursing level. If a PA, correct me if I'm wrong, but if a PA is writing orders or anything, it must be co-signed or have some formal physician interaction. So a nurse can't take a verbal order from a PA. So it really makes that working cohesion on units harder. Once we get that regulation in place where we can start working a little bit more synergistically with each other, I think it will move to a much higher level. But that lack of regulation right now is a huge barrier for some placements. So again, I know that you're working towards that, and I anticipate eventually it will come. Other steps that I can see as an NP is just making sure that the PAs fit the areas. I think that there have been PAs that have gone into an unwelcoming environment with lack of clarity, and that hasn't helped the situation. I think in some ways it has hurt the PA program. And you've got to, you know, everybody knows change, we hate it. Yes, consensus building, oh my gosh, don't talk about theory yet again. But it's out there and you have to do all of that. And I think that's where, if anything, the direction needs to go for all the professions. So I'm going to stop there, because I think everything else has been said.